And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of the end. I will rise, we will rise, we will rise, we will rise.
Hello, my name is Michelle Zabel and my pronouns are she and her. I'm an assistant dean at the University of Maryland School of Social Work and the proud director of the Institute for Innovation and Implementation. Today, I'm just delighted to welcome you to this Training Institute live workshop. As you might have come to expect with all your favorite conferences, the Training Institutes are now virtual. And although I know we'd all like to be together in person, we are excited to host the virtual Training Institutes and really want to encourage you to continue to join us on the first Thursday of every month through August. Each month, you'll have a choice of 2 back-to-back workshops. So mark your calendars, choose your workshops, and make sure you reserve your place early so that you can attend the workshop that most interests you. Today, I want to encourage you to actively participate by using the chat to post your questions, post your comments, and share your resources with your colleagues. Our presenters, they definitely want to hear from you. And it is absolutely your participation that will make each of these sessions a success. As a reminder, staff are monitoring the chat and they're going to make sure the facilitators see your questions and comments, so be sure and engage. A few other reminders to include: if you need assistance at any time navigating through these virtual spaces or accessing links to workshops, we do have a live help desk support standing by to assist. We are also providing a certificate of attendance after the completion of each workshop, and all of our workshops are being recorded, so by you participating, you're implying consent. Finally, there will be an ASL interpreter or closed captioning available during each workshop. Those interpreters can be pinned when available for those who require interpretation by hovering over the interpreter's video and selecting the 3 dots. One of the options that will appear is pin video. By selecting the pin video, this video will not move out of view. With our theme, What Could Be? Bolder Systems and Brighter Futures for Children, Youth, Young Adults, and their Families, all of our sessions will challenge us to envision a future where the voices of children, youth, young adults, and their families are elevated, especially those who are most frequently silenced or marginalized, where we use the best data and research available to challenge ourselves, developing new ideas and approaches that can be implemented to meet the needs of youth and families, and in service of our commitment to social justice and the elimination of disproportionality and disparities. My hope is that today's session will provide you with food for thought as you consider your next steps in creating a vibrant, equitable future for youth with complex needs and their families. Please don't forget to register for next month's workshop. Remember, they're held the first Thursday of every month, and you can visit the institute.umaryland.edu for the full schedule. Thank you so much for joining us, and I look forward to seeing you next month.
Sorry about that, had to unmute there. So good afternoon, everyone, unless you are in Hawaii. I'm Eric Bruns, and it's great to be with you here from the office of my backyard and Seattle, Washington. I'm a professor in the Department of Psychiatry and Behavioral Sciences here at the University of Washington School of Medicine, and today I'm very pleased to be here for this latest installment of Training Institutes Live, which is entitled Use of Hierarchical Clustering with Optimal Transport Distance Measures to Analyze Performance of Algorithms on Standardized Youth Mental Health Data Sets. And actually, of course, I got really burned by my 9-year-old this morning, so I had to share the love a little bit. That is actually a very bad April Fool's joke. What we're actually going to be talking about today is something that is extremely near and dear to my heart, probably just about everybody who's joining us, and certainly my co-presenters. And we're going to be talking about, which is even more exciting than complex hierarchical statistical analyses, how do we make best use of all we know about what works for children, youth, and families in the mental health realm and children's services realm more generally, and make it actually work in the real world. And so the real title of today's session is From Evidence to Impact, Implementing Effective Equitable Mental Health Services for Youth and Families. So as a co-director of several centers, the University of Washington School Mental Health Assessment Research and Training Center, the National Wraparound Initiative, and I'm also very proud to be affiliated with the the Institute for Innovation and Implementation at the University of Maryland School of Social Work. It is our all-consuming passion, and that is not an overstatement, that we move beyond just generating more evidence about what works under ideal conditions and ask, what have we learned from just lessons learned in the field as well as implementation science to make those evidence-based practices work in the real world for all of our youth and families. And so I'm so pleased to be joined today as well by two wonderful colleagues in the implementation science and mental health services field, who will be adding to the content today by presenting on how to adapt implementation strategies to achieve greater racial equity and reduce disparities in access and outcomes in youth mental health. And those two folks are here on the screen with me: Larissa Gaias, assistant professor in the Department of Psychology at University of Mass-Lowell, and a former postdoctoral fellow at our UW Smart Center. And Kimberly Arnold, who is an NIMH postdoctoral fellow currently in mental health implementation science and academic community partnerships at the Penn Center for Mental Health at the UPenn School of Medicine. So let's go ahead and get started. Today, our goals are fourfold. The first is really the most fundamental and overarching topic here, which is how important it is to put on an implementation headset in all the work we do. In the work we do, building systems of care, running organizations that provide mental health services and other supports to children, youth, and families, being a practitioner. I'm going to talk about some basic implementation science terminologies, but with examples very specifically to the question of how do we achieve better outcomes and access to mental health services and children's services more generally in systems of care. Along the way, we're going to talk about multiple levels of focus for strategies that we can use to increase effectiveness. So recognize that there are different kinds of strategies we have to use at the individual practitioner level, the program level, the system level, and a level that often isn't talked about very much, which is what do we need to do about adapting interventions themselves to be more feasible, more equitable, more acceptable. Third, we're going to talk about choosing implementation strategies at each level to increase the success of implementation and provide examples from children's systems of care. Relatedly, Larissa and Kim are going to talk about a framework called Aspire that can allow us to consider how implementation strategies can be paired with evidence-based practices to increase equity and reduce racial and ethnic disparities in mental health service access and outcomes. And that's very much in keeping with some of the context that Michelle provided at the beginning about what we're looking to focus on in these training institutes live and in the work we do with children's systems of care. So it's just great to be here. Let's start with a little poll. So you've heard who we are. What best describes your role? It's always very interesting. Looks like we've got a couple hundred folks here almost. Please take a moment to tell us who you are. Are you working at a state level? Are you working at a program or organizational level? Are you a practitioner? Are you a family or youth advocate or family or youth run organization leader or member? Are you a researcher or evaluator? Who is in the room with us here today? While we're filling that out, I see we've got a whole bunch of comments already, which is great. I've got a great team here. We have a great team here from the Institute who are going to take those comments, and if there are questions or comments, bring them to bear to the whole group at the end of this session. So please use that chat box to ask questions or make observations or comments. So let's go ahead and close out this poll. Looks like we've got a lot of program level leaders and practitioners pretty much tied for first, in fact, exactly tied for first, 35 each of those roles. We also have a good number of system leaders, good number of family or youth advocates, some researchers, and some folks who say that they serve some sort of other role. So thank you so much, Khalil and team. Let's go to one more poll, kind of keep folks engaged here. So why are you here today? I'm trying to figure out how to advance the slide. There we go. Why are you here? So real interested in this even more so. Some options we put out there are, we're implementing one or more new programs and want to ensure their success. Or maybe we've been implementing a strategy for years and are kind of rebooting it, trying to ask how we can make it better. It could be that we're attempting to increase equity and or address disparities and seeking ideas on how to do so. And a good number of you probably are here for general information on implementation and systems of care. So I'm watching the results come in here. Thank you all so much for doing that. Over 100 folks already voted. Good 2/3 of you are doing the polls for us. So while I'm watching this come in, a good number of you are here to just get general information, which I think is great. Everybody who's doing this work in children and youth systems of care needs to be thinking about how we kind of tool our strategies and interventions to be most effective, and using implementation science is one way to go about that. But I'm really interested and impressed and excited about the fact that the second highest poll result here was the primary focus here is about increasing equity or addressing disparities. So we're going to want to make sure that we leave plenty of time for presentation and discussion about from Kim and Larissa about some examples from school mental health and children's systems of care about how we can do so using implementation science. So that is fantastic. Thank you all very much. All right, so let's talk a little bit about the background here. How can implementation science help our quest to improve behavioral health for youth and families? Now, one thing I want to just kind of start out by saying is that implementation science is a relatively new kind of buzzword in our kind of field. Let's just face it, we've been doing implementation science and systems of care in positive behavior supports in schools, in all sorts of the fields that are relevant for decades. Implementation science is kind of referred to as something kind of new and exciting. It provides a framework for something that we've done in so many different ways. As leaders, as practitioners, as system folks, we've been asking, for decades, since before the beginning of the system of care movement in the 80s, how do we figure out how to make what works work better? The system of care movement, system of care strategies are all about teamwork, use of data, training and professional development, financing strategies. These are all examples of implementation strategies for effective programs. So when we talk about implementation science, what it really brings to bear, I think, is kind of just a new way of packaging and then investigating what some of the best ways to do that kind of work are in a way that cuts across all the services and supports we provide to kids and families. The quest here is to use those strategies, that work in our systems of care. So we talk about evidence-based strategies, but let's be clear, this is not just what is the best research evidence. This is also coming from practitioner and family members and partners experience and our system leaders, as well as youth and family preferences. And this is something that's a very well accepted definition of evidence-based strategy from the American Psychological Association, Institute of Medicine. It's not just about what has had controlled studies done on it. And I think that reflects the way that systems of care work as well. Some examples of what works. Again, it's not just about manualized psychosocial treatments. Things that work include school-wide social emotional learning programs and mental health literacy. The research shows that when you do high-quality social emotional learning in schools, that you can increase academic achievement on average 13%, meta-analysis found. So that's an evidence-based strategy. Parent-to-parent peer support or youth-to-youth peer support is an evidence-based strategy. Wraparound care coordination. We literally just this week published a study that came out in the Journal of the American Academy of Child and Adolescent Psychiatry that showed from 17 controlled studies that wraparound care coordination on average confers medium-sized, significant positive effects for youth with emotional behavioral needs. And then, of course, there are certain common factors of providing care that are evidence-based. They're not manualized, but these are things that we should do because they work. And that includes things like measurement and feedback in service delivery, consistently asking, are we making progress towards our goals with a family or a youth? Are we feeding that back into the process? And then, of course, hundreds of specific psychosocial interventions. But what gets in our way? Here are some classic examples. Train and pray, right? We're not asking what kind of ongoing professional development support and how we provide that to practitioners to make sure that what they get trained on is effective. But it's even more fundamental than that. Sometimes we pick strategies that are intended to fit everybody when they're really only going to be well suited to a small segment of our population. So we use the one-size-fits-all approach without asking how to match to preferences or the population we're trying to serve. Then there's of course, the is legiat strategy. In other words, it seemed like a good idea at the time. We can't let a couple people make decisions without assessing what the needs and preferences are of families and practitioners. And of course, there's the kitchen sink approach, where we pile more and more things onto our systems and practitioners without asking how to de-implement stuff that's already being done. A classic and amazing study on the kitchen sink approach provides one example of an implementation strategy that's needed, which is assessing what the need is and making sure that we are fitting our evidence-based practices to the need in a strategic way. Bruce Chorpita, Eric DeLeiden, and others on their team took a look at how many evidence-based practices does it take in a system of care to provide maximum coverage of youth problem areas, for instance, by age and gender. And so what they found is that if you just implement a single EBP, if you choose it carefully, you can meet up to a third of the needs of youth in a typical system of care. So for example, if you choose an evidence-based practice for depression, or maybe justice involvement, you can meet a good proportion of the need. And if you pick a second, maybe you have one for externalizing disorders, one for internalizing, you can get to 50%. But what happens is as you choose more and more evidence-based practices, the return on your investment levels off more and more, to the point that if you picked 100 evidence-based practices, you wouldn't be covering any more youth needs than 6 or 7, maybe even, arguably 4 or 5. So let's be careful about how we choose our practices right from the beginning. So you've picked your EBPs, you've picked your strategies. What are we going to invest in? What happens next? Unfortunately, this is all too often the case. Another part of the problem we have to overcome. So here's Dilbert, right? Or I guess Dilbert's boss. I'm back from training. I got a big binder. The training's already forgotten, but the binder will last forever. A living monument to temporary knowledge. So we also have to ask, in addition to careful selection, how do we actually cultivate the use of the things that we're selecting? And this is where implementation science comes in. It's moving from letting it happen, just putting stuff out there, to making it happen. Some of the terms in implementation science at a real fundamental level are diffusion versus dissemination versus implementation. Let's be careful right from the get-go about what it is we're choosing to do with our systems of care and the strategies in it. Diffusion means just letting it happen, perhaps providing organizations with manuals or some, in this day and age, it could be videotaped training, video recorded training materials. Dissemination moves beyond just diffusion of information. It's about helping it happen. Perhaps you're beginning to provide some coaching. Perhaps you are providing structured training, maybe some measurement and feedback. Implementation goes beyond just helping it happen to making it happen. And that means taking a really comprehensive look at all of the things you need to do at multiple levels to help get those really important strategies that you've picked to actually work for children and families. And again, let's recognize that this is school-based supports, peer-to-peer supports, evidence-based psychosocial interventions, and all the strategies that we are trying to do. All right, so here's your little implementation science 101 to set the table for some examples of what we need to be doing in our systems of care from an implementation kind of perspective. The big picture takeaway from this, whether you're looking to achieve greater racial equity and reduce disparities, whether you're just trying to get a program that has been identified by your stakeholders as being critical done well, we have to put on an implementation headset. It's the biggest takeaway about this whole session. What does it mean to put on an implementation headset? Let's talk a little bit about some basic terminology here. So next few slides, I shamelessly stole from my wonderful colleague, Kara Lewis at Kaiser Permanente. And here's her Twitter handle down here. So to put on an implementation headset, be a champion for thinking these things through systematically. Here are some terms that might help you. I'm only going to focus on a few because this is hardly a comprehensive course on implementation. But here are a few key terms and definitions to think about. The first is implementation outcomes. We know all about what kind of outcomes we're trying to achieve for youth and families. In wraparound, we're trying to keep them at home, in school, and out of trouble. And we really try and focus on those outcomes for individual youth and families and for an entire program. Implementation outcomes are the things that have to happen to get to those outcomes. We'll talk about them. Other terms we'll talk about briefly here are determinants of practice or implementation success. And then a big one we're going to talk about today is implementation strategies. And that's going to go all the way to Larissa and Kim's part of this presentation. Carefully selecting implementation strategies and modifying them as needed to make sure that you are achieving all the outcomes you're seeking to achieve, including equity and reducing disparities. So big picture, implementation outcomes. This is the effect of our actions to implement systematically treatments, practices, strategies. So we talk a lot about client outcomes, and that's where you have to be living day to day, is asking, are we doing a good job on these things, where kids are living, they're functioning, their symptoms, satisfaction. And sometimes we know that to get there, we need to get fidelity, efficiency, and so forth. When you're putting on an implementation headset, we're also asking about implementation outcomes. Are the things that we're choosing and the things that we're providing acceptable to practitioners and to families? Are those practitioners actually adopting these practices? Or, as I've seen way too many times, we train and then find that not a single unit of high fidelity practice ever got done. So are we adopting the strategies we're trying to get out there? Costs, feasibility. Can we find a way to make sure that what we're proposing to implement is actually feasible before we invest tons of hours and dollars in getting it done? So that's an implementation outcome, that something is ultimately found to have been feasible for their workflow. All right, so again, this is a real overview here, folks. So implementation outcomes are important to getting to our client outcomes. How about determinants? These are factors that might get in the way of or enable implementation success or outcomes. So here we're trying to change professional behavior, attitudes, adoption. How do we do that? What are the barriers, like this little railroad barrier here? Or what are the facilitators that get us climbing to new heights of implementation. Why don't we take a break here? I've been talking for a good 10 minutes straight. What are some key determinants? Type them into chat, and Raj is going to tell us a little bit about what you're seeing in the chat. I can't open it up or I'll get totally confused, but type some things that from your mind, from your perspective, your experience, are determinants of actual successful implementation. What are the things that make it happen or get in the way? Throw them into the chat, and I'm seeing the chat numbers go up like a Vegas casino here. Ding, 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 ding.
Yes, we have staff turnover, buy-in, resources, organizational culture and resistance / support of change, administrative support, high turnover, staff turnover again, engagement, data. We have some more staff buy-in, clinicians, curiosity, organizational climate, lots of compliance, lack of support from management, seeing efficiency of change, leadership teams wanting to do it and make a change.
Yeah, a lot of attitudes, climate, culture, but also tangible things like resources, time, turnover. That's fantastic. So we know the things that get in the way or facilitate our change processes. The question is, how do we make this systematic? Do we identify these and take them on, again, systematically? That's our task here. So that's where we turn to implementation strategies. Thank you so much for reading out the chat there. This is where we turn to the implementation strategies. And this is kind of the crux of this session, right? What methods or techniques are we going to use to enhance adoption of practices and sustainability? These fall into some categories that we should all, again, have in our implementation headset. So one thing is planning strategies, doing needs assessments before we jump to a solution, visiting the service sites to talk to folks, observe what the current flow is. Education strategies. They're often used, maybe not always super efficiently or effectively, but they're critical. So you take the time to have those meetings about what is it we're trying to achieve system-wide or in your organization. Education strategies also might be about making training on a certain strategy more dynamic. Huge in systems of care, finance strategies. Can we adopt capitated payments or per member per month instead of fee for service? Do we alter the incentives? Can we do pay for performance to do more family-centered care or more evidence-based practice? Restructuring strategies. Systems of care, once again, how do we fundamentally change the way money is shared, people collaborate? Revising roles, setting up in wraparound, we set up entire care management entities so we get away from fee for service being done, because research, as I'll show you, shows that that's better. Quality management strategies. People said data in the thing we were just reviewing in the chat. So auditing and feedback. And then, of course, policy context. Changing requirements, liability laws, certification requirements. So these are the strategies that we need to be looking at. And you'll be seeing soon that we've got a compilation of 75 of them we want to share with you in a few minutes here. So finally, mechanisms. So real quick, those strategies are intended to achieve some sort of mechanism that will make change happen. So when we decide to do data-informed coaching to get to better fidelity, we're addressing a determinant, which is skills. The mechanism is skills acquisition. So again, putting on an implementation headset, we know what we need to achieve. We might select a strategy. What's the mechanism that we're trying to accomplish, such as increasing skills? But it could also be, like you all said, maybe it's attitudes that's more important. Maybe it's misconceptions. Maybe it's payment. So analyzing the determinants, selecting the strategies, and evaluating the impact is multi-level. And this is all about systems of care, but it's also in school mental health, which Kim and Larissa and I also share a real passion for, thinking about tier 1, tier 2, and tier 3 strategies, classrooms within schools, within districts, within systems. Everything is multi-level. So another thing to do in your headset is think about things in a multi-level fashion. At a system level, our strategies and our determinants, again, they're about policies, regulations, laws, funding, huge, funding's huge. At an organization, like people said in the chat, climate and culture, leadership, training and supervision. Individual practitioners, again, people said this in the chat, knowledge, attitudes. People said stuff about attitudes and mindsets, many different ways just now, and that's huge. There are ways to get at that. And then finally, at the youth and family level, are we picking things that fit what their needs are and their preferences about how they get them? So we have to think about this at a multi-level kind of way. We also need to think about it in a staged way. So there is a framework called the EPIS framework, the Exploration, Preparation, Implementation, and Sustainment framework by Greg Ahrens and colleagues. So the EPIS framework says that there are different things we need to do at different phases to get stuff done. At the exploration phase, again, do those kind of site visits, talk to families, talk to practitioners. What's the fit between the proposed practice and their needs or their current flow? Assess that fit, assess system issues. It's all about kind of asking the hard questions before you jump to a solution. Then you make your adoption decision. You don't do that first and then regret it later. I'm going to tell you right now, I've done that. I have experienced that firsthand, and I've been complicit in that adoption without exploration. It is, you know, if there's one thing to kind of take away from this, it's do that first step of work of talking to folks about the idea or the needs before you make an adoption decision. Then you've got preparation. You're not yet implementing services, but you need to think strategically about what you need to do to prepare. Do you need to market this? Do you need to explain it? Do you need to educate? Do you need to change routines? An example again from wraparound. Develop a specialized unit for your care coordinators. If they're mixed in or have multiple jobs, they're not going to be as effective. What do you need to do to prepare to do this? And then you begin your training and coaching. In implementation, focus on the leadership and support. Have regular problem-solving meetings, use data, examine turnover. Constant problem solving is where you're at with implementation. And hopefully you're getting your EBP delivered with fidelity. And you do CQI assurance, supervision, and turnover management to keep it going well. Takeaways. Think about your implementation headset being both about multi-level and multi-phase. Poll time, keep you engaged here. You probably have a strategy in mind. What phase of implementation do you think is most critical to the program or strategy you're interested in? Is it that pre-implementation phase? Are you getting ready to even make a decision about a program or strategy? Are you planning and preparing to implement? Are you in implementation? Or are you at the phase of sustainment? Real interested to see what people say is kind of the critical phase that they would need to think about strategies. Getting some good votes here, pushing up to 50%, hopefully keeping you with us. Some folks are saying not sure. I'm seeing responses all across the board. A lot of it's in the planning and preparation, but close behind, tied for second, is pre-implementation or exploration and sustainment. So across the whole array of phases of work is where people are at. I am really glad that folks are identifying that they are at the pre-implementation or exploration phase. Please think about how you can adopt some of the strategies we'll show you for preparing to even make a decision. The rest, the biggest response is planning and preparation. There's a ton of strategies we'll show you in our resources as well there. All right, thank you all very much. Okay. So, pulling it all together, I just need to get a joke in there. So there's pulling the multi-level and multi-phase stuff has resulted in framework overload, over 100 unique implementation science frameworks. And it just gives me the opportunity to tell my colleague Aaron Lyon's favorite joke or riddle. Why are frameworks like toothbrushes? Anybody know? If anyone gets this right, actually a couple people should, because they were in, I always tell this joke. So the answer is because everyone has one and no one wants to use anybody else's. That's why implementation frameworks are like toothbrushes. But the important thing again, frameworks that we use to keep on track are multi-level, implementation has discrete phases, and there are consistent domains we need to pay attention to. The important thing is to have a framework that works for you and helps you explain what you're doing. Keeps you on track, keeps you thinking about what kind of strategies you need to pick and what you need to measure. So a very commonly used one is the CFR, the Consolidated Framework for Implementation Research. So this is our little version of the CFR that we use at the National Wraparound Implementation Center. And it really is just here to reinforce that implementation has a manageable number of domains to manage and measure. Some of those domains, first and foremost, outcomes for youth and families. But what gets to outcomes? A whole lot of things. That's why all these little pieces kind of touch it. Implementation success and all those implementation outcomes. But we also have to look at individuals. We have to look at the strategy itself. And then, of course, as we've already reinforced, the organization and the system level both have to be considered. One thing that often isn't considered, along with the intervention itself, is what about our implementation process? How are we going about making this change to a new approach happen? So these are things to think about. I'm going to go ahead and skip this poll, make sure I get done in time, and give you a few strategies, a few examples from youth mental health of looking at what you're trying to accomplish and making some decisions about implementation support. So one is straight from the wraparound field. Wraparound care coordination is something that I've been doing for 20 plus years. It started as a care coordinator, and that's how I decided to get into this research. In the 90s, when I was in grad school and became a care coordinator, wraparound was a really radical, important new idea in systems of care, but no one had ever done a study of it or created any fidelity measures. So that was something I got involved in. We now know what some of those determinants of high quality wraparound implementation are, and barriers. So barriers we hear in the system, wraparound is being done in 46 states at least across the country. We hear the same themes all the time. Care coordinators can't pay for all the support that their families need. They can only do fee for service for professional services. Care coordinators have many other jobs. Care coordinators don't have access to the services that they need. So thinking about solutions, again, system level. This is all a big system level example. Let's do case rates rather than fee for service. Takes a lot of work to get your state plan amendment done and stuff, but you got to do it. Require a specialized organization instead of mixing care coordination into your community mental health centers. Figure out how to have a broad and diverse service array. So the system fix here for increasing numbers of states builds on Wraparound Milwaukee, blending funds from all the systems so you don't have silos. Create a single organization that does care management. That care management organization contracts with 210 providers in Milwaukee, at least when this slide was created 10 years ago, and has a contract with a family organization for family-to-family peer support. And that's where the work happens. And they have a case rate. So all these system fixes many years of work, and it's going on in places like South Carolina, Louisiana, New Jersey, all sorts of states. How do we know it works? We've done the research. The care management entity model, like that of wraparound Milwaukee, we looked at the efficiency of implementation, and we found that these orange bars are the care management entity states versus the blue bars, which are those that use community mental health centers. The care management entity states took much less time to install wraparound than if you have community mental health centers that tend to have fee-for-service care coordinators mixed in with others. They have to use their local CMHC's services first. So that was great, and it encourages better quality of care. So you measure and think of fixes at the system level. This just shows that fidelity in 5 CME states has been found to be better than in those states that use community mental health centers. So that's your system level example here. Let's talk about program level examples. I heard at least 5 people in the chat say turnover. How do you select strategies to reduce turnover? First, you identify that this is a problem. My colleague Rick Shepler from Case Western does this for his intensive home-based treatment programs he provides consultation to. It's about taking hard looks at this and bringing people together to strategize. So things to decrease, over unrealistic productivity expectations, reducing paperwork, making sure your supervisors are available, and then increase supports and rewards. So this is our quick program level example of implementation supports of an evidence-based practice. Provide clinical supports more consistently. Provide competitive salaries. Sounds so simple, but we don't do it in this field. But there are ways that you can do that. Make sure there's flexible schedules, opportunities for advancement, tech support. All right, so again, program level, real concrete strategies. That's all we're talking about here. And then an area that we often don't talk about in children's services or mental health services. What about the intervention level? A quick thing to point out is that there is no implementation of an evidence-based practice without adaptation. You can't pretend that you're just going to take a manualized program and do it as is in a real-world system. You have to adapt it. Service outcomes, like symptoms, functioning, well-being, are downstream. Upstream, our interventions have to be efficient. They have to fit to the practitioners. They have to make it easy. So one last example in the school mental health field that I just obviously love to talk about because it's something that I did. Let's talk about our design goals for evidence-based practices. This is real quick, the slides will be available, but they need to be learnable and efficient. And so many of them are not. So in your pre-implementation, assess the usability of the thing you want to do. And if it's not, but you still feel like you want to use it, ask how you can make it more usable. So an example from school mental health. Here in Seattle, we work with these school-based health centers, and they all have a clinician. We were trying to figure out how to get them to do evidence-based practice that would fit the needs of such diverse arrays of kids and do it efficiently, because they have essentially caseloads in high schools of like 200, 300 students who might have needs, and they're one person. So we came up with an adaptation of evidence-based practices called the Brief Intervention for School Clinicians that is focused on collaborative problem solving and use of data. So you take the common elements of evidence-based care, some of these common factors like using data, engaging, and using problem solving, and have that be something that's done in a 4-session package, where the evidence-based practices like stress and mood management, looking at the cognitive triangle, you only break them out when that core strategy of problem solving is not working for the youth. And after 4 sessions of problem solving with bringing this small number of evidence-based techniques to bear where needed, you reassess with data. So boiling it down to something that fit these school clinicians. And we were really excited to see that it actually got more evidence-based practice implemented in the schools that we tried it in. So our brief intervention for school clinician had more elements consistent with evidence-based practice. And we found that the brisk youth showed improved functioning after just 4 sessions. So we were really excited about that. Last 5 minutes of my piece, and then we're gonna hand it over to Kim and Larissa. Summing this up, consider your implementation strategies carefully. Again, there is a whole array of these. I believe that one of my team members is going to put in chat a link to a PDF of a compilation of 75 implementation strategies. They fall into categories like planning, educating, financing, policy, quality management, and restructuring. Just gave you some examples. This is hardly a comprehensive review of how to do this, but it's important to put that headset on and recognize that there are strategies that fall into some pretty consistent categories to consider. And that our job is to select them carefully based on data and information and make them happen out there in our systems of care. It's a pretty straightforward concept here, according to my friend Kara Lewis. The steps are simply identify those determinants of whether a strategy is going to be successful or not, prioritize the determinants that you want to focus on, and select your strategies, carefully considering what the mechanisms are that are most important across those levels. When you assess context, a little note about that. A lot of our evidence-based strategies have system and program level checklists to consider that is specific to that strategy. So determinants at the system and organizational level, and they have assessment tools for the system and program level. So in wraparound, we have an implementation standard assessment. In positive behavior supports, there's things like the district systems fidelity inventory. So find these relevant resources and assess where you're at so that you can inform your selection of the strategies. In wraparound, for example, we know outcomes are highly dependent on program and system factors. Here's the URL for where to find the National Wraparound Initiative's Handbook of Wraparound Implementation and Practice Standards. So it enumerates these things. Do you have eligibility, like a very systematic eligibility determination process? Do you have the right funding approach? Do you have the right staffing ratios? Are you doing workforce development appropriately? So again, summing up, regardless of whether there's such tools available or not, we need to find, sorry, apparently my child is printing something for school here. I hope you don't hear that too loud. Think about your determinants and match your strategies. Here are some examples. Lack of knowledge, interactive education. Practitioners think they're doing something right, but reality is not the case. You got to use audit and feedback strategies. One moment while I explain to my child I'm presenting to 200 people. I'll bring it to you shortly. Sorry about that. This is the realities that we're all living in right now. Lack of motivation can be addressed by incentives or sanctions. A lot of folks said beliefs and attitudes in the chat box before. And so asking who your opinion leaders are that you want to instill with the charge of selling this strategy and being present at meetings is a strategy. And then of course, you saw an example of when systems aren't working, the collections of policies and financing, you got to do a full process redesign, as has been done in states that are using care management entities now, like I showed you that example. All right. Strategies are often misaligned with determinants, so do this carefully. So again, putting it all together, just can't provide enough of these examples, right? Provider knowledge deficit leads to education as the implementation strategy. Your mechanism is to build awareness and knowledge, and you're going to get to implementation outcomes. Provider skill deficit, training, teaching and practice with corrective feedback. The mechanism is skill acquisition. Providers view the strategy unfavorably. Implementation strategy, provision of descriptive social norms, including peer use of the strategy, and so on and so forth. There's so many examples. All right. So again, I think you have an example or a document that pulls from Byron Powell's paper on compiling implementation strategies. Gotta love that it's the ERIC project. They did it for me, the Expert Recommendations for Implementing Change project. And you'll see in that compilation of strategies that, again, they group together to help folks kind of consider what you might specifically do to achieve implementation success by looking at the strategies at those different levels and at your correct phase. And that's what it looks like. So, main take-home points from me. All of this stuff, all of this kind of jargon is just about trying to help folks have a really well-stocked toolkit so that they can put on an implementation headset and be real creative and think about doing whatever it takes, just like in Wraparound for Families, doing whatever it takes and not being lazy about our strategies that we're going to use to both select and then support implementation. Implementation's multi-level and phased, and assessing implementation determinants. What are the barriers and facilitators is a first step. So with that, I am really excited to talk about taking implementation science to a new level and examining implementation strategies through an equity lens. And I'm going to turn it over to Larissa Gaias and Kimberly Arnold. And I'm going to be advancing the slides, but I'm going to go on off camera for a sec so I can hand my child her math worksheet. There you go.
Thanks, Eric, and thanks all for being here today. And so that was a great overview of implementation and specifically about implementation strategies. And that's going to be really helpful context for our discussion on really how to consider equity more explicitly when you are selecting and using implementation strategies. So we know that pervasive racial and ethnic disparities, as well as disparities across other dimensions of identity, exist in both the access to, quality of, and outcomes of mental health supports. So even when youth have similar levels of need, youth of color may be less likely to access supports, and even when they do access supports, often face lower levels of retention or acceptability of these, and quality of supports, which ends up translating often into disparities in the outcomes of mental health interventions. Since the goal of implementation strategies is to improve access, quality, and effectiveness of adoption, implementation, sustainment, right? All of those implementation outcomes that Eric was talking about, we may expect that using implementation strategies may help facilitate equitable mental health outcomes. Eric, you can click one. But it is critical to consider what may occur if we're not explicitly considering equity when we're selecting and using our implementation strategies. So for example, one of those implementation strategies from that ERIC compilation that Eric was showing is within the domain of use evaluative and iterative strategies. So this implementation strategy is to obtain and use family feedback. This sounds like a great, you can stay. This sounds like a great strategy for ensuring that interventions are designed, right, to actually address the needs of youth and families, and therefore may enhance adoption and outcomes of the evidence-based practice. But what if we're only involving families who already tend to have access to decision-making processes within mental health contexts, right? Families who may already be involved within these processes. These families may be more likely to be well-resourced, well-connected, white middle-class families. And therefore, the intervention may be designed and implemented according to the needs of these families, right, using this implementation strategy, but may end up exacerbating or maintaining disparities instead of reducing them. Now you can move ahead, Eric. Thank you so much. So considering the need to really think through equity when we're choosing and using these implementation strategies, some colleagues and I, Kim and some other colleagues, proposed a 3-step process that we refer to as ASPIRE. And ASPIRE stands for Adapting Strategies to Promote Implementation Reach and Equity. And this is a process for adapting implementation as they exist to really have a more explicit focus on equity. So, right, if you look through those 75, implementation strategies that are in these compilations, how can we, as we're considering which one of those 75 to choose, how do we want to ensure that we're really centering our focus on issues of equity? So the first step in this process, as you're choosing strategies, is to really identify and understand the underlying assumptions of the implementation strategy. So how and why is the implementation strategy supposed to work? This is what Eric was really talking about in terms of mechanisms, right? How is the implementation strategy supposed to have its intended outcomes on implementation and on mental health outcomes? And what would need to be true about the implementation strategy for those implementation and mental health outcomes to actually be equitable? Okay, so once we're really understanding kind of the mechanisms of an implementation strategy, the second step is to identify the potential sources of disparities that might exist if you were to use the implementation strategy without that explicit equity focus, right? So you may consider, okay, who is involved in the implementation strategy? What resources might be necessary to engage in the implementation strategy that may not be equitable across contexts? What is the process for enacting the implementation strategy? Is there room for disparities to arise as we're actually using the implementation strategy as written? And what might be some outcomes of the implementation strategy? And is there maybe room for disparate outcomes of the implementation strategy to emerge? And once we really have a clear lens of what those assumptions are and the potential sources of disparities, we can use that to really actually go ahead and adapt the implementation strategy. So not a huge departure from the strategies that were compiled, but how do we adapt those strategies to ensure that equity is really explicitly being considered in those underlying assumptions and explicitly has the potential to reduce disparities? So things we may want to consider, right? They go along with step 2. What are the necessary people and actors to be involved in the strategy? What are the processes or steps that need to be enacted? What outcomes need to be considered? Thanks, Eric. So I'm going to walk through, we can advance. I'm going to walk through one example of these strategies. So one strategy, again, within those 75 are to use advisory boards. And the definition of this strategy is to create and engage a formal group of multiple kinds of stakeholders to provide input and advise on implementation efforts and to elicit recommendations for improvements. This is an important strategy. And for step 1, what are the underlying assumptions of this strategy? How are advisory boards, supposed to function? Advisory boards can provide expert consultation to streamline implementation and avoid barriers. So you may have people who are, experts, implementation experts who can really support this implementation effort. Advisory boards can also provide tangible resources, including social capital, to really support that implementation. Advisory boards may also provide informal oversight and accountability to implementation developers, to the implementers themselves, the intervention developers, to the implementers themselves, and maybe also to those who are, the end users or beneficiaries of the intervention. Another assumption about the function of advisory boards is that members of advisory boards will be authentically incorporated into decision making, that they're not there just as kind of talking heads or token pieces, that they're given real decision making power within the implementation process. So, okay, now we really have a good sense of how advisory boards are supposed to function. But are there any potential sources of disparities within this implementation strategy? So one potential source of disparities is what I had mentioned related to the other example I gave, right? Advisory boards may be chosen based on existing connections and may require resources like schedule flexibility or childcare, right? So therefore, membership on advisory boards may include disproportionate representation of people who are well-connected, well-resourced, again, potentially have an overrepresentation of homogeneous white individuals who, again, are already well-connected and well-resourced to a lot of our kind of systems of power, right? And this may not actually reflect the implementation context. So decisions that may be made are using the expertise of people who may not actually reflect the context. And also, when we think about the process, some group processes may not actually allow for authentic participation, especially of those from marginalized identities who, again, may be tokenized, where they're, who may be tokenized and who may not be, provided with the opportunity to provide maybe a dissenting voice within the process, and where there may not actually be room for disagreement within these advisory boards. So both this is a matter of who's involved as well as the processes embedded within these advisory boards. So step 3 is to adapt this implementation strategy to really ensure that equity is in the underlying assumptions and has the explicit potential to reduce disparities. So what might this look like? So instead of the initial definition, we may create, prepare, engage, and support the authentic participation of a formal group of multiple kinds of stakeholders, representative of the demographic makeup of the school. We work in school mental health, so a lot of these examples are grounded in schools, to provide input and advice on implementation efforts and to elicit recommendations for improvements. Ensure a process that elicits honest and safe participation and also allows for conflict resolution. So this is the way that you're taking this initial strategy and adapting it to really center on ensuring that there's equitable participation and equitable processes. Next slide, Eric, thank you. So this is just a table. I'm not going to go through it, but I think it was shared in the chat. So in the paper that we wrote, we go through multiple examples because, again, we believe that this process can be applied, this 3-step process, to the 75 strategies that are compiled, those 75 implementation strategies. So we just provide some additional examples of progress monitoring, promoting adaptability, supervision, partnerships, and local policy. So again, those multi-level that Eric spoke about. But again, this is just to serve as examples because the goal is to choose implementation strategies that are really well aligned with your context and with the evidence-based practice that you are going ahead and implementing. Go ahead, Eric. So that was, as I was mentioning, these implementation strategies, we want to really consider their fit with the intervention itself, as well as with the context, because the overall goal, right, is to really increase the benefit of the intervention for those who face the greatest disparities and the highest levels of marginalization within our mental health systems, as well as and who face the highest levels of disparate outcomes. So in order to do that, we need to be thinking of equity of the intervention itself, equity in our context, and equity of the implementation strategy, which we're talking about within the Aspire process. And we want to be choosing implementation strategies as they fit with the context and as they fit with the intervention that we're implementing ourselves. And Eric, you can just click once more. And just to re-emphasize, so when we are thinking about equity of implementation strategies, we're thinking about equity of participation, equity of resources, equity of processes, equity of mechanisms, and equity of implementation outcomes. And not all of these may apply to every single implementation strategy, but they're the different options of things to think through as you're choosing and adapting implementation strategies. And implementation strategies do not live in isolation, right? We are pairing implementation strategies with interventions themselves. So what I'm going to provide one example, and then Kim is going to provide another example of how we really thought through how to pair implementation strategies with specific interventions in order to enhance equity, both in implementation processes, as well as equity in the outcomes themselves. And you can advance again, Eric, thanks so much. So one intervention that I've been really involved with over the past few years is EMR, or Establish, Maintain, Restore. This is a universal student-teacher relationship intervention that's designed that the goal is to enhance social emotional outcomes and prevent school dropout. So teachers are trained in concrete relationship building strategies to establish initial relationships with students, to maintain those relationships over time, and to restore relationships after there's been a negative interaction or a conflict that's occurred. And in addition to being trained on concrete relationship building strategies, teachers are also trained in what we call the Emr Equity Levers. And these are, again, concrete strategies to reduce biases as we're engaging with relationship building strategies to make sure that we're building equitable relationships, because we tend to build relationships with people who tend to be most similar to us. So we may actually, through using EMR, we may not be reducing disparities. So that's where these equity levers come in. How are we paying explicit attention to equity and reducing biases as we're engaging in relationship building practices? Next slide, Eric. So as we said, we are firm believers that it's critical to have implementation supports along with our interventions. So you don't just go to a 6-hour EMR training and then are expected to perfectly maintain EMR over the course of the school year. So part of EMR are also our critical implementation supports, which includes weekly emails, some consultations, as well as professional learning communities, which is what I'm going to focus on here. So Eric, if you can advance again. So teachers attend a monthly professional learning community where the goal, and this is our critical implementation strategy that we really chose to be a core part of EMR. So in the PLC, teachers are really there to reflect on and to share with one another, reflecting on how their relationships, building may have gone the previous month, as well as to action plan for building relationships in the month to come, right? And there's a lot of protocols for this reflection. But one thing that we built in as we were thinking, okay, what's the mechanism of the PLC? What is the process of the PLC? And how is this really actually going to continue to enhance the use of these equity levers? So part of the reflection is a roster reflection where teachers are asked to reflect on students within their class and to reflect with students in their class who might be in that established phase, who may be in that maintain phase, and who may be in that restore phase, right? And kind of the ideal phase is maintain. So we asked teachers, do you see disproportionate representation of students in the established phase or in the restore phase, according to race or ethnicity, according to gender, according to special education status, or free and reduced lunch? And if you're seeing that you have higher, a racial disproportionality in who you're seeing these really kind of conflictual relationships with, or students you just have not built a relationship with at all, maybe in this next action planning, we really want to think additionally about how we're going to incorporate more of those equity levers. So that was an implementation strategy, the professional learning communities, where we're really try to put an explicit focus on making sure there was an equity component within that process so that we didn't lose that focus over the course of the implementation period. And that was one example, and I'll turn it to Kim for our other example. Thanks so much.
Hi, everyone. So the Relax, Be Aware, and Do a Personal Rating intervention, called RAP Club for short, is a trauma-informed universal school mental health intervention that was designed for adolescents living in low-income urban settings. So RAP Club is focused on the prevention of potential negative effects of chronic stress and trauma exposure. The core components of RAP Club are based on evidence-based practices for mental health, including psychoeducation, mindfulness, and cognitive behavioral therapy. These strategies have been shown to be effective for adolescents, especially those exposed to chronic stress and trauma. RAP Club is a 12-session group-based program, and each session lasts for 45 minutes to an hour. The intervention can be delivered by lay school staff, including teachers and athletic coaches, or a mental health clinician, along with a young adult community member. RAP Club was implemented in 29 Baltimore City public schools as part of the Project Power efficacy trial from 2016 through 2019. Implementation resources to implement RAP Club during the trial were provided by the research team and partner schools who decided to adopt the intervention. Unlike most efficacy trials that only involve the research team and delivery of the intervention being tested, the RAP Club intervention involves school stakeholders and community members during all phases of implementation, including training and delivery of the intervention. Next slide, please. So prior to RAP Club being delivered and implemented as part of the Project Power efficacy trial, a team of researchers, Black adolescents and young adults, and community advisory board members worked together in accordance with community-based participatory research principles to successfully adapt RAP Club from structured psychotherapy for adolescents responding to chronic stress to be a prevention-focused school mental health intervention. So first, academic researchers built a partnership with a local nonprofit community-based organization that was co-founded and led by Black community members. Next, they co-created a community advisory board that consisted of members from the community, including Black adolescents and young adults, local universities, and the local health department. Then the community advisory board identified unmet mental health needs among local Black adolescents and young adults. Then researchers selected Sparks based on the mental health priorities identified by the community advisory board. Next, the community advisory board reviewed the Sparks curriculum and confirmed its appropriateness for use with local Black youth. Next, Black young adults from the community were hired as consultants to assist with adaptation of Sparks, along with researchers and the community advisory board to enhance the cultural responsiveness and appropriateness of the intervention. Researchers then further adapted Sparks to be delivered in schools, and RAP Club was born. Last, Black young adults helped implement the RAP Club intervention in Baltimore City public schools during the pilot phase, as well as during the Project Power trial. So overall, building partnerships, forming a community advisory board, promoting adaptability of evidence-based interventions, and engaging intended intervention recipients in implementation efforts are all implementation strategies for enhancing implementation and sustainability of school mental health interventions and promoting health equity. In this case, careful attention was given to building partnerships and forming a community advisory board with Black community members who would be the primary recipients of the RAP Club intervention. Additionally, Black adolescents and young adults actively participated in the adaptation of Sparks and in the implementation of the RAP Club intervention during the pilot phase in 2 schools and the Project Power efficacy trial in the 29 schools. And I was also part of the implementation of RAP Club in a couple schools during the trial. And at this time, we are happy to take any questions, and thank you all for attending our training today.
Yeah, thank you so much, Kim and Larissa. We had one question that was I think, very specific to Kim and Larissa, and I am going up to find it here. Where did it go?
I think it's about how do you know when diversity is reached and is not unconscious bias.
There you go.
So I think it's important to, recognize that diversity is not, an end outcome that we're going to achieve and then and then there's, an endpoint there, right? It's something that we're really continuously trying to improve these equitable outcomes. So I think my first response to that is to make sure that we're really progressing towards a focus on equity, on anti-racism, in order to not, kind of have some checkbox that we're looking to complete. But that being considered, one thing to really think about is what are those intervention outcomes and how are we evaluating our intervention? So something that we do in EMR is we are both, we have multiple forms of evaluation. This is something you can think of as an implementation strategy as well as what are we monitoring as outcomes, right? So we monitor, so we have teacher outcomes, right? So we are examining teachers, some scales on multicultural teaching competencies, on their use of the equity levers, right? We have specific, scales for that we ask students both quantitatively and qualitatively about how they're perceiving equity in student-teacher relationships. And we also are disaggregating study results, right? So we're not, and this is something that's in one of those Aspire examples, is by ensuring especially if you're, implementing an intervention to a heterogeneous, a diverse group, right? So you're not necessarily focused on something that's only, being implemented to one particular group. Are you seeing that there are stronger intervention effects for students who may face marginalization within school, school context or other mental health contexts, right? Are we seeing, as a result of our interventions, that we're closing any disparities that may have existed at the beginning? So it's really important to both evaluate our interventions using an equity lens, and that when we're interpreting those evaluations, if we see disparities, that we're interpreting those disparities that we're seeing not through a deficit lens, but as further information for what we can do as evaluators, as implementers within our systems to focus even more on equity. So that's how it's kind of an iterative process. So I hope that answers the question. I would love for Kim to add on from your experience as well.
I think you covered it, Larissa. Like, I completely agree and don't have too much to add to it. So it's just that when we're really working in this space and trying to achieve mental health equity, we have to just pay close attention to not only the intervention itself, but the strategies that are being used and having equity as an outcome as well, so that we can ensure the reach of the intervention. Did it reach the intended recipients? Was there a diverse pool of recipients? And especially in the context of schools, in which sometimes when we're delivering interventions as part of a research study, sometimes only a small subset of students are receiving the intervention. So it's really important for us to work with school partners to figure out ways to scale up the intervention in an equitable way so that other students within the school who could benefit from the intervention have the opportunity to receive it as well.
Kim, I do think that there's a specific question about the RAP Club, or maybe it's about Spark and it's adapted or not, but someone asked, is this something implemented in other school systems? I do think that was specific to Spark, but it could be about EMR for all I know. So maybe both of you just take that on real quick.
Sure, and I can start. So as far as I know, so Sparks was an individual intervention for adolescents, and so it wasn't necessarily a school-based intervention. So I'm not sure the extent to which it has been implemented in schools as an individual intervention. But for a RAP Club, it was only implemented within Baltimore City Public Schools within that school district. And right now, since the trial has ended, the outcomes of the trial are being analyzed, and we do hope to disseminate the intervention to other school districts after we finish analyzing the data and assessing the effectiveness outcomes of the intervention.
And it was confirmed that that was about the RAP Club. So thanks for that answer. I'm kind of curious, maybe even go into Sparks or RAP Club or EMR, let you all take this one on as examples, since you all gave very specific examples of some specific interventions. Once implementation occurs, how do you assess the success and the success of each individual provider? And maybe it's also success overall. So what are some methods used in either of those two?
I can start. So for the RAP Club intervention, we actually use a combination of self-report as well as observations to assess the implementer's performance. So on the self-report side, after each intervention session, each implementer had to complete a fidelity log that asked different questions about their delivery of the intervention, and they had to also rate their own effectiveness in delivering the content, both the core content and examples. And then in addition to that, we also use observations in which each intervention session was audio recorded, it was videotaped to ensure accuracy and fidelity of the intervention. And then it was then viewed by a research team member who was not part of implementation, and they had a separate fidelity rating sheet to then rate the implementer based off of their performance.
And I'll share a bit about EMR if that's so. In EMR, we have multiple mechanisms for this, but one, so teachers report on their own fidelity, but we also have PLC attendance, right? We, as well as teachers shared those PLC protocols and forms with us. So we could look both at whether they attended the PLC, but also how, how complete kind of that protocol was. We could look at some of their reflections around, the equity reflection, the action planning and things like that. But I want to kind of also connect it to the implementation context level that Eric was talking about earlier, because in our case, the implementers, the teachers are also nested within schools. So we were also asking teachers as well as administrators about the implementation context, both through interviews as well as through surveys, and are now examining whether some of those fidelity outcomes or sustainment outcomes differed based on how strong that implementation context was, whether there was individual buy-in, teacher, administrator buy-in, whether there were resources within the schools for implementing EMR, what the social norms for EMR was. So in addition to evaluating, individual provider, I'm forgetting what the word was, but kind of fidelity or use of the strategy, we're also able, because of the structure, able to look at the school level, whether there are any, CFER determinants, so barriers and facilitators that impacted that individual provider. So the school context allows us to evaluate student outcomes and teacher outcomes, as well as those contextual outcomes that Eric really emphasized earlier in this presentation.
Yeah, and wraparound, we've really moved away, frankly, from too much emphasis on individual practitioner level fidelity, because especially with wraparound, which is really a systems level intervention as much as a individual youth and family intervention, it's about retooling systems to be more family and youth driven, more effective, more individualized. We do coaching at the individual, at the wraparound provider organization level. So I didn't have time to put that in as an example of a audit and feedback or CQI strategy, which is one of those 75 strategies. But we do it at an organizational level and at a system, sometimes a state level. So we're literally at the National Wraparound Implementation Center, taking those implementation determinants at the system and organizational level. For implementation nerds, that's the outer context or the inner context, and translating them into coaching tools that we continuously collect data on and use as the basis for action plans, all the way up at the state level. An action plan might be about revising your Medicaid state plan, doing a Medicaid state plan amendment, or standing up an entire new service line at the state level. So yeah, that is a good reinforcer. The EMR example is a good reinforcer of the need for data at those levels as well as at the individual practitioner.
Okay, Eric, we did have another question. It says, some early research on systems of care looked at what seems like outer system level changes and tried to tie those to impact of child outcomes. Based on your framework, that seems like a significant flaw in thinking in that research. Seems like all of the levels should be considered in research and evaluation.
Yeah, I would agree. I mean, that's, I think, where implementation science has kind of provided some better kind of frameworks for thinking through both how to support implementation, but also how to evaluate it and how to do research on it. When you have that headset on, you're always asking yourself, well, can we validate this hypothesis? Now, we found for wraparound, which really adopts a lot of the system of care principles at the organization and system level, that those implementation determinants at the system level, broadly defined as, do you use a care management entity approach that has case rates, unique care management units, professional development just for these staff and so forth, did that relate to fidelity and outcomes? And the answer is clearly yes for fidelity, clearly yes for implementation success and efficiency. And we're now looking at the question of outcomes at a state level and asking whether or not wraparound enrolled kids in those states improved more rapidly when you have a care management entity approach to wraparound. And there have been a couple other studies that did find that. So I think, you know, we won't go too much into the early systems of care research, but I think there's been a lot of critique of just looking at one or two such communities and not really asking about all of the array of implementation supports kind of was a flaw in some of those research studies. A lot more has been done since that's relevant.
And the final question we have is for Eric. You mentioned your work by Tropita and colleagues looking at multiple EBPs. I know they use a module approach. Can you explain that briefly?
Right. So the research that I presented about how many EBPs does it take to kind of provide coverage is kind of an extension of their distillation of the evidence. So they review all of the research out there that is rigorous enough to meet criteria and asking, what are the elements of those packaged evidence-based practices that are best associated with child outcomes in the research? So not looking at the big, thick manuals, of which there are literally hundreds. Those manuals and those programs often just kind of have different combinations of the building blocks. So for, you know, just child disruptive behaviors, it might be about praise or star charts or whatever. Those are elements. So if you boil down all of the elements of all those evidence-based practices, it's ironically actually more manageable than trying to ask what's the evidence for the programs themselves. And so, yeah, they have an entire thing. If you want to go check it out, go to practicewise.org, and they have a whole system for querying their research base about what specific clinical techniques would I use, not which big manualized program would I go start using, but which techniques might I use as a therapist if I want to get at this problem area. So yeah, that's the research that they've done, and an entire shift in how we think about evidence-based practice resulted.
Okay, thank you.
So I think we're at time.
Yeah, so at this time, I'd like to offer a chance for each of the presenters to say any last final thoughts or comments.
Thanks for putting up with my bad jokes. Larissa and Kimberly, any parting words, or we can just each say thank you so much? And thanks for joining us.
Yeah, thanks a lot. And, love to connect with anyone who may be interested in specific programs or thinking about equity and implementation. So just so glad to have spoken with all of you today, and thanks for being here.
Yep, feel free to email.
Yes, thank you all for attending today.
And thank you for letting me know my jokes weren't too terrible in the chat. All right. Have a great rest of your week and weekend. Fill out the evaluation.
So thank you to our outstanding presenters, Eric Bruns, Larissa Gaias, and Kimberly Arnold, for sharing your expertise and strategies with us today. And thank you to our interpreters, Elaine and Wanda. And thank you to you all for joining us for this segment of the Training Institute's Live. A reminder to register for future workshops. The next one is Thursday, May 6th. The link will be posted in the chat. We also would very much appreciate if you just take a few moments to complete the evaluation for the workshop using the link that's also posted in the chat. We take the feedback seriously, and it will help us shape upcoming workshops in this series. Again, thank you for joining us today, and we look forward to seeing you on the first Thursdays of each month for the Training Institute Live.